Thank you. Thank you very much. I am not Maddie Payne. I'm Argyris Stringaris, who has a computer problem today, and Dr. Payne kindly lent me hers. She's on another computer. I'm the chair of Child and Adolescent Psychiatry at UCL, and I'm delighted to be chairing the session with two of my favorite scientists, Professor Harmer and Dr. Krebs. We'll start with Professor Harmer's talk. Kath was a person whose talk I heard when I was a trainee, and I really, at that point, I thought I must work at some point with this person, but how am I going to do this? And I couldn't find a way. But after many years of trying, we managed to work together on a grant. She's the PI on with the Welcome, and you're going to hear about that and all sorts of other fascinating things that she's been doing. She's professor of cognitive neuroscience at Oxford. She is the head of the psychopharmacology and emotion research lab and associate head of department of psychiatry at Oxford. And the person who first spoke to the world about early cognitive changes happening through medication, and therefore kind of revolutionizing our understanding of how medication might be working. So without much further ado, I'm handing over to Professor Harmer.
Thank you, Argyris. And actually, it's me that's been desperate to work with you for many years, so it's nice that we have made it happen. Right, I will share my screen and over here. Does that all look okay?
Yes.
Great. Well, thank you very much for the invitation to take part in this Catalyst seminar. I think it's a great idea, and I'm really looking forward to discussing this work and drawing links and parallels with Georgina's work and ideas as well as we go through and in the discussion. And so I'm going to be talking about mechanisms of action of antidepressant drug treatment during adolescence. What do we know already, and what do we need still to find out? So we all know, of course, that adolescence is a critical time of development, particularly in terms of our mental health. Depression often starts for the first time during this time period. This is where rates of depression start to increase, and it's associated with a range of risks, such as risk of suicidality, poorer educational, physical, and social outcomes across the lifespan. So timely and effective intervention is really important. Clinical guidelines such as NICE recommend that you start with some kind of psychological treatment and then move on to SSRI medication if this is not effective or if you have a particularly severe case of depression. But despite this kind of note of caution around the use of antidepressant medication in adolescents, the rates of antidepressant prescribing have really increased over the last 20 years or so. There's this much discussed paper by Jack et al., which shows that rates of SSRI prescribing have doubled in children and adolescents over a 10-year period. And you can see some of these data over here on the right in the graph, showing, this is just in girls, showing a more than doubling of rate of SSRI prescribing between 2008 to 2018. That's that solid line there. So there is increased use of SSRIs in adolescents and in children. But are SSRIs effective in this age group? Of course, this has also been much discussed, and there's been a number of different reviews and meta-analyses which have brought together the different evidence in different ways. This is the network meta-analysis by Zhu, who compared the efficacy and acceptability across all types of different intervention for depression in children and adolescents, so including these drug treatments here, but also psychological treatment in these head-to-head comparisons. And you can see there are a number of things to see from this plot. One is that the color coding here, that most of these different treatments has a very low quality and quantity of evidence. There's not much work looking at all of these different types of treatment in this age group, which I think is really shocking given how important it is in terms of development. And the second thing to point out that most of these treatments don't separate, therefore, from the placebo line, the zero line here, but the only ones that do is the SSRI fluoxetine, including CBT or fluoxetine alone. And you can see that there's the most evidence base, both in terms of benefit, but also in terms of risk for this age group. And because of this bigger data for this SSRI for fluoxetine or Prozac, this is the main one which is recommended for this age group. But at least there are some studies looking at efficacy of antidepressants in young people. When it comes to looking at mechanisms, there's next to none. Very few studies have looked at controlled randomized studies trying to understand how these treatments may work in the adolescent brain. And I think, again, that this is quite a shocking state of affairs, because if we don't understand how treatments are working, then we have little hope of improving them in the future. And so understanding the mechanisms of treatment is really useful. It can provide us with a model of how treatments may work so that we can look for new and improved treatments. If we understand the key targets which are affected by effective treatment, we could integrate these into the clinic, and it might allow an earlier prediction of response, which is particularly useful in this age range where there's always this question between risk and benefit. And I think also that understanding mechanisms can really help to reduce stigma to do with taking these kinds of treatments. And you're probably all aware of the media discussion the last year or two about the kind of lack of understanding of what causes depression and how antidepressants work. And this lack of understanding has really caused great concern amongst the public and patient groups, who often report that they feel that they shouldn't be taking a treatment if they don't understand how it works, and that it's increasing pressure to not take these kinds of treatments, even if they are working for that individual. So lack of knowledge really has all kinds of knock-on effects. This was one of the main conclusions that we reached in our active ingredient review, funded by the Wellcome Trust with Argyris here, that really there is a huge gap between the widespread and increasing use of SSRIs in young people and the science and the mechanistic science on which this is based. And so this is the gap that I would like to focus on today. And so when we think about mechanisms of antidepressant drug action, you can think about all kinds of levels of analysis and all kinds of processes that might be involved. I suppose most people would start to think about neurochemical mechanisms or synaptic, molecular, cellular mechanisms, but we can also look at the brain and associated cognitive processes. So, for example, how antidepressants affect core cognitive processes involved in depression, such as affective bias or reward sensitivity, and the neural circuitry which are underpinning these kinds of cognitive processes. And we can also consider how these kinds of effects might interact with the environment to lead or to get translated into differences in subjective experience. So how changes, for example, in affective bias may interact with the kinds of stimuli and the kinds of situations and the kinds of life stresses that you're under, and which may play a role in how well you respond to this kind of treatment. And so I've spent most of, well, quite a big part of my career looking at the effects of antidepressants in adults on this so-called negative affective bias. This is where depression tends to be associated with an increased propensity to identify, to focus on, to remember negative over more positive pieces of information. So given the same life stress or the same everyday hassle, if you have a negative bias, you are in effect receiving and pondering on more negative information, which of course can reinforce many of the symptoms and experiences of depression. And so just going to give you a quick demonstration of how this kind of negative bias can play out in practice and in everyday situations. So here you are you're walking through the beautiful park in London and you see Argyris, but to your surprise, he just walks past you. He doesn't say a word. He ignored you. Not sure if that's ever happened to anyone here, but it might make you think, well, he doesn't like me, it's because I'm stupid. On the other hand, you're walking through the park, see Argyris, he totally blanks you. And you might think, well, he was probably deep in some very complex philosophical German thought about next steps in his research, and perhaps it's not about me at all. And so you can see how these different perspectives and different perceptions and interpretations could actually lead to you feeling quite differently, and how you feel and how you behave and how you go about the rest of your day. And these kinds of negative biases are also seen very prominently in adolescents with depression. Susie Murphy's recently been looking at some interviews that were done with depressed adolescents who were asked to describe what depression felt like to them and what depression felt like. And the predominant theme in these interviews is really this description of having a negative bias. And you can see this in all kinds of examples. And so you can see this one quote, this person says, "I remember once this girl said, well, you'll never get a boyfriend because you're just ugly. And rather than hearing that once when it happened, every single morning I would look in the mirror and there she was, you're ugly, you're really ugly." So very recurrent, difficult memory that really coloured ongoing perception. And a lot of people can actually reflect and comment on this negative bias. You could kind of realise that you're doing it, but still it's so compelling that it's difficult to let it go. And so this individual says, "The world becomes distorted and it appears as if it's against you. It's a very tiring thing to go through and completely destroys any motivation, confidence and self-esteem that you may have had." And so we've done quite a bit of work looking at the effects of antidepressants on these kinds of negative biases in perception and memory in adults. And so this was our first step to look at whether something similar was happening with antidepressant drug treatment in young people. So to look at this affective bias, we tend to use these kinds of facial expressions of emotion, where we present these kinds of faces and ask people to identify which emotion they can see. And so you can see this is a happy face, and then in the middle, it's an angry face, and then it's a sad face. And we make this task really complicated because we don't show the video like this, which is easy to recognize. We take every intensity level separately and intermixed with all the other emotions. So you really feel like you're guessing. And when people who do this test who are experiencing depression, what they often see is less of these positive facial expressions and more of the negative faces like anger and sad. And so we wondered whether an antidepressant commonly used in adolescent depression, fluoxetine, would be able to influence this kind of emotion perception in an experimental medicine model. So this was in young, healthy people aged between 18 and 21. And you can see the results here. So this is accuracy in the recognition of these different emotions with placebo in grey and, placebo in blue and fluoxetine in grey. And you can see that even though this is just one dose of fluoxetine, there's a reduction in recognition of anger and sadness and an increase in the recognition of the happy facial expressions of emotion. So it suggests that even in young people with this SSRI fluoxetine, you can start to see a change in how people are processing emotional information well before they start to feel better. So it may be an important foundation of what happens next. And so then we wanted to see if we could translate this to patients with depression. So this was a study, so it's a small study in 29 people who were prescribed fluoxetine for depression, aged between 13 to 18. So we managed to get them through the CAMS clinics, multiple clinics, just as they were prescribed fluoxetine, but before they had taken their very first dose. So it was quite an undertaking. It was a double-blind randomization of this first dose, either with fluoxetine at 10 milligrams or placebo. And then we particularly looked at the neural response to these emotional facial expressions in fMRI after 6 hours, which is when the peak dose of peak levels would be expected to occur of fluoxetine. And what we saw was that, again, just this single dose of fluoxetine could affect how the brain was dealing with this emotional information, and across key areas such as the amygdala, the ventral hippocampus, and the anterior cingulate. And you can see the data here for the amygdala. So this shows the activity in the amygdala, so the happy and the angry facial expressions. And you can see that even this quite low dose and single dose of fluoxetine has reduced the amygdala response to anger versus happy facial expressions of emotion. And we know that the amygdala is really important in detecting key and salient stimuli in the environment, things which need extra attention and processing or response. And so this really looks like the kind of neural correlate of the behavioural change that we've seen, that the amygdala is much less interested in the negative versus the positive facial expressions after this single dose of fluoxetine. But this is a very small study. It's more like pilot data really, to show that it is worth looking at even very early treatment with this SSRI in young people. And so what we're doing now is that we were very fortunate to get a mental health award from the Wellcome Trust, where we aim to develop a more complete experimental medicine model of SSRI action in young people. There's a number of different steps. The first is that we want to expand the kinds of neuropsychological constructs that we're looking at, with a further deep dive into irritability or proneness to anger, which was hinted at by the changes that we saw to angry facial expressions, a focus on peer sensitivity, reward, and affective bias. And so the first year is going to be about improving or selecting the right measures together with young people with lived experience to think about the relevant constructs and how we can best deploy them. And then we're going to look at the effects of fluoxetine on these neurocognitive markers, both in behaviour and with high field fMRI, so we can start to look at the subfields, for example, of the amygdala and how they may be modulated by this kind of antidepressant drug treatment. We're also working with Emma Robinson in Bristol, who has developed a very nice rodent model of affective bias in adult rats, but now as part of this is going to translate this into adolescents. So again, we can do more mechanistic work, trying to understand how and when and how these changes occur with early treatment with SSRIs during development. Then we're going to see if these early changes are relevant to later clinical response. Is it that people who show the greatest improvement in these emotional processing biomarkers then go on to show a better clinical response? And this would be really useful because, of course, it's very difficult to know who's going to respond to an antidepressant, and particularly in this age group where you need to weigh up the risks and benefits very carefully. And then work package 5 is a focus on the effects of SSRI withdrawal. This is going to be led by Argyris at UCL, looking at the effects of SSRI withdrawal on these neurocognitive markers. And this was the inclusion of this in the proposal was a direct result of input that we'd had from our lived experience advisors, who spoke a lot about the worry about antidepressant withdrawal and what it would mean, whether it would make them worse, which actually feeds into the decision about whether to take an antidepressant in the first place. Using this study and a parallel one in rodents, we can look more at the underlying processes that might be occurring during withdrawal, being able to differentiate between different hypotheses, as you can see in this graph here. So we would predict that you have a sort of latent vulnerability to depression and negative bias on these measures. And when you take SSRI treatment, this comes down. But when you stop taking antidepressants, it probably returns to where it was before. But one hypothesis that we want to differentiate from is whether actually there might be an enhanced risk or an enhanced negative bias in the early weeks after withdrawal. And we'll be able to look at that in more detail through these studies. So lived experience is really important to this project. It helped set the priorities for this whole programme of work, and particularly this focus on withdrawal. Here's a quote from one of our YPAG advisors, but I don't know what it's going to be like to try and come off them. I'm pretty nervous about that. And actually there's very little work on adolescent withdrawal of antidepressants, largely because I think fluoxetine has quite a long half-life, and so most people would assume that withdrawal wasn't going to be too difficult. But of course it's really important to understand more what might be happening during withdrawal in this age group. And this is going to be particularly important in year 1, where we come up with the tasks and the constructs to tap into these key aspects, we hope, of antidepressant drug action. And so if you know any young people who'd like to join this YPAG, we're currently recruiting, and the application process is open. So please do contact me if you'd like to hear more. So what we're trying to do with this kind of project is bring together different expertise and different ideas about depression and its treatment across pharmacology, psychology, psychiatry, social context, in ways that often these things are considered separately. I hope that understanding more about the mechanisms will improve how treatments are developed and understood in the future. As you can see in the diagram to the right, going from the lab directly into the clinic can be really difficult. It's very difficult to go from a test tube into a real life situation. And hopefully this process of experimental medicine, where we understand more about a drug treatment early in its development, can really help improve the way in which we translate these new compounds. And it may also be useful for identifying non-response earlier in patients taking SSRIs, as it has been seen in adults, particularly for resolution of symptoms of anxiety. And then this focus on SSRI withdrawal, I think, is probably long overdue. And I'd just like to end by thanking everyone who's been involved in this work. Here are the investigators of this Wellcome Trust grant, along with researchers that are working on setting up the YPAG groups and the task development, our collaborators, and all of our lived experience advisors and participants. Thank you.
Well, thank you very much, Kath. Thank you, Professor Harmer, for an excellent talk. I'm sure this has stimulated a lot of thought and questions. We, as usual, we're going to have these at the end. I would like to ask now Dr. Georgina Krebs. Dr. Krebs and I work closely together. I'm actually very happy that I get the opportunity to co-direct our anxiety, self-image and mood lab together, as well as our clinic of the same name. I've known Dr. Krebs since we were together at the Maudsley, working in Dr. Heyman's clinic. Georgina is the world expert in body dysmorphic disorder in adolescents, having also developed a treatment in it, and we're delighted that she will be talking to us about mechanisms of treatment in this and other conditions. Georgina, yours.
Thank you very much for the introduction. I will just share my slides. Hopefully you can see this.
Yes, all good.
Yeah. Okay. Thank you so much for the introduction, and it's a real pleasure to be able to join this seminar and speak alongside Professor Harmer. As Professor Stringaris has said, I'm going to be talking about mechanisms underpinning improvement in psychological therapy for anxiety and depression in young people. A lot of the work I'm going to be talking about is work that Professor Stringaris is leading, so I hope I do it justice today, and feel slightly nervous talking about it on his behalf. But I will just start with a brief recap, talking about anxiety disorders in young people. Can I just check? I'm not sure. I've got a dual screen situation going on, and I'm not sure if you're seeing the
We can see
presenter view.
you very, very well.
Yeah,
Yes,
okay, fantastic. All right, thank you. So anxiety disorders in young people, I'm sure everyone here is very familiar with the significance of anxiety disorders, but just to recap, these are a group of conditions that usually develop early in life during childhood and adolescence. In fact, 3 in every 4 individuals with an anxiety disorder will have had an onset before the age of 25. And these are very common disorders in young people with a point prevalence of about 7%. In fact, they're the most common group of mental illnesses in youth. And there's some indication that they may be on the rise as well. Anxiety disorders are very distressing and impairing. And after depression, they've been ranked as having the highest disease burden of all mental illness. So clearly, timely and effective treatment is really important. And the NICE guidelines recommend cognitive behavior therapy as the first-line psychological treatment for all anxiety-related conditions in young people. And there's really a robust evidence base for CBT for anxiety disorders in youth. And we see typically response rates of about 60% across trials. So pretty good outcomes. But we know less about how CBT is working, what the mechanisms of action are. What we do know is that one of the key active ingredients in CBT for anxiety is confronting feared situations. So for example, if you have a spider phobia and you have CBT, your therapist might encourage you to gradually face up to spiders in different situations. And in behavior therapy, this is referred to as exposure. And really it's based on learning theory, and the original understanding of it was anxiety habituation. So the idea was that if you face up to your fear and you stick with that situation, your anxiety will gradually subside over time. And if you keep practicing that same exposure, it will get easier with practice, and eventually your anxiety will extinguish altogether. But although we know that exposure works, it is effective, in recent years, findings have called into question whether habituation really is the mechanism underpinning its effect. And in fact, there's a building body of evidence now indicating that fear reduction doesn't mediate change in exposure-based therapies. So really where we're at is that we have effective psychological treatments for anxiety disorders in young people, but the mechanism underpinning these is poorly understood. And as Professor Harman has already discussed, understanding mechanisms is really key to us improving our interventions. And clearly, although interventions are effective, there's still plenty of room for improvement. So this is an important avenue for future research. And I'm going to be talking about some research that we're doing to address exactly this question in one particular anxiety disorder, and that's social anxiety disorder. So social anxiety disorder is characterized by a fear of saying or doing something embarrassing or silly or boring and being judged negatively by other people. So for example, somebody with social anxiety might think, I'm going to look like a nervous wreck. People will think I'm stupid. And these kind of cognitions understandably tend to lead to avoidance of social interactions and social withdrawal. And this can fuel more generalized negative beliefs about oneself. So for example, the belief I'm unlikable and I'm no good. So often people with social anxiety disorder develop this very negative self-concept. And so perhaps it's not surprising to hear that social anxiety disorder is commonly linked with depression. And in fact, up to 70% of people with social anxiety disorder also meet diagnostic criteria for depression. The gold standard treatment for social anxiety disorder is cognitive therapy, and we know it's a highly efficacious treatment. So this figure shows data from a recent randomized control trial by our collaborator Eleanor Lee in Oxford. And you can see here that cognitive therapy, which in this study was delivered online, was associated with really amazing outcomes at post-treatment and at follow-up. What's really interesting is that as well as improvements in social anxiety, there are really substantial improvements in depression as well. So these are session by session scores from the same trial, and you can see that depression is improving over time and really quite closely tracking changes in social anxiety symptoms. And in this study, the between group effect size for depression was large. It was a Cohen's d of 1.5, which is substantially larger than is typically seen in CBT for depression trials. And of course, we have to be cautious in making these indirect comparisons, but nevertheless, it does seem to be the case that cognitive therapy is working really well for social anxiety and also for improving mood. So how is it working? Well, our hypothesis is that experiencing positive social surprises is what is really important. And I'm going to explain by what I mean by positive social surprise. So if you think of somebody with social anxiety having a conversation, they'll have a range of negative cognitions. So for example, thinking, I won't have anything to say, I'm going to freeze, they're going to think I'm boring. And these are essentially negative predictions or expectations about how the conversation is going to go. And we suggest that for therapy to be successful, it's really essential that people with social anxiety have the experience of positive social surprise. That is, the outcome of the conversation or the interaction is better than they expected. And it's this mismatch between the prediction and the outcome that we refer to as surprise. And it's often talked about as being prediction error or expectancy violation in the literature. And prediction error is well known to be a key mechanism of learning in general. And in the case of social anxiety, we suggest that it enables the person to learn something new about themselves and perhaps about other people and how the world works as well. So for example, in this situation, the person with social anxiety might learn, actually, I'm better at chatting to people than I thought, and I can enjoy social interactions. We also suggest that there might be certain cognitive and behavioral processes that get in the way of positive social surprises in day-to-day life for people with social anxiety disorder. And one that we're particularly interested in is the process of self-focused attention. And what we mean by self-focused attention is a tendency to reflect excessively on internal thoughts and feelings and beliefs. And that tends to come at the expense of attending to one's external environment. And we think that if you're really stuck in your own head and very internally focused, that could impact on positive social surprises in a couple of different ways. One is that if you're really self-focused, it might actually be objectively hard to engage in a conversation, to concentrate on a conversation. And that might mean that the conversation actually doesn't go that well. And there are data indicating that when people with social anxiety are self-focused, they actually perform, if you like, less well in conversations, according to an objective rater. But the other way in which self-focused attention might get in the way of positive social surprises is that even when a conversation does go well or better than expected, it might be difficult for the person with social anxiety to benefit from that experience, to notice it, and to realize that actually the outcome was better than they'd expected. So we've set up what we refer to as the surprise study to test these hypotheses. And this is led by Professor Stringaris. And really the core hypothesis that we're testing is that improvement in social anxiety and mood in young people relies on positive social surprises during social interactions. And this is work that's been funded by the Wellcome Trust, and it's a 5-year program of research involving 6 work packages. We're taking a range of different approaches, but the work that I'm going to talk about today is the experimental work, which is really the starting point for our program of research, and it's the foundation for the subsequent work that we'll carry out. So over the last 9 months or so, we've been working on developing a novel experimental paradigm that will allow us to test the causal role of social surprises in improvement in anxiety and mood. And we had various requirements for this paradigm, and it hasn't been entirely straightforward to develop and has been through lots of iterations. So just to sort of talk you through some of the requirements, as it were, of course, we wanted the paradigm to involve some kind of social environment so that it would elicit symptoms of social anxiety. And we wanted this to have some level of ecological validity as well, to be relevant to young people's day-to-day lives. We wanted the paradigm to be set up so that we could manipulate social surprise. And we define surprise as the discrepancy, the mismatch between the outcome of a social interaction and the expectation that one has beforehand. So within our paradigm, we are wanting to manipulate both the outcome and the expectation. And I'll talk in a little bit about how we do that. It was also important to us that this experiment was something that could be delivered online without an experimenter present throughout, so that it would be scalable and we could collect data from a larger sample of young people, which was particularly important for some of the later analyses that we want to carry out involving fitting computational models. And again, this is actually quite a big challenge. This isn't a trivial thing, because when you look at most experimental paradigms that have been carried out with social anxiety disorder, they tend to involve a conversation partner. So the social environment is a conversation and relies on somebody else being present. And so we had to think creatively about how we could create a social environment that didn't rely on a conversation partner being present. And we also wanted the paradigm to be a multi-trial. So we want to be able to, within person, test the effect of varying social surprise in different directions on mood and anxiety, and to, as I mentioned already, later fit computational models. So where we've got to, and this is still work in process, is developing a paradigm which is delivered online, and it's set up where participants are told that they're going to be meeting and talking to a group of virtual players and getting feedback from these virtual players. So this is an example of the screen that participants see at the start of a trial. They're told that they've been paired up with a virtual player. In this case, they're told they've been paired up with George. And they're also told how the player usually rates people. And the histogram at the bottom indicates the sort of typical ratings of the player. And this is done in order to manipulate expectations. So essentially, we can set up expectations that the virtual player is a very harsh critic, or an expectation that the virtual player is somebody who's very generous and positive. And this we hope will manipulate subjective predictions. The core task then is that the participant is asked to describe an image for 15 seconds, during which time their camera is on and their audio is on. And this is to give a sense of being observed and evaluated. And this is deliberately not a cognitively demanding task. And it's also a task that doesn't have a right or wrong. And we designed it in this way because we didn't want to be eliciting performance anxiety per se, but rather the sort of social component of talking to somebody is what's important. So they're told there's no right or wrong, but just describe the picture as best you can. After that, they're asked to make a prediction about how they will be rated. And then they're given a rating from the virtual player. And this rating is, again, something that we manipulate, so we can either give a positive outcome or a less positive outcome. And lastly, we ask participants to rate their mood and anxiety. So there are 48 trials in total, and participants are paired up with a range of different virtual players during this time. And so I guess to recap, essentially, we're manipulating and measuring both the expectancy, the prediction, and also the outcome. And from this, we can calculate what we refer to as subjective prediction error for each trial. And I'll just show you now the results from some of our pilot studies. We've carried out several pilot studies now, and these data come from the most recent ones. So this is data on 42 participants scoring high on social anxiety who were recruited via Prolific. Each line represents one participant and shows the association between subjective prediction error, so that mismatch between their prediction and the outcome, and mood across trials. And you can see that there is a positive association. So what this means is that the more positive the prediction error, the more positive the surprise, the better the mood. Interestingly, when we look at the association with anxiety, it's weaker, which isn't necessarily something we would have expected. And we're not sure whether this is to do with the measurement issue, the way that we're taking the ratings of anxiety, or something more fundamental. So it's something that we're looking into at the moment. But nevertheless, we're encouraged that it seems we can successfully manipulate social predictions, and this does have an effect on mood on a trial-by-trial basis. I won't go into detail about our subsequent steps, but just to highlight that this is the early stage of this work, and we're at the moment working on integrating manipulation of self-focused attention into the experiment as well. And then we will be going into schools to test a large number of young people who have elevated social anxiety and depression. So why is all this important? I think there are several reasons. One is that if we can identify surprise as being one of the key mechanisms of change, then it will give us clues as to how we can enhance and improve efficacy in treatment by maximizing surprise. It also might help us think about how we can simplify treatment. Cognitive therapy for social anxiety disorder is quite complex, and although it works really well in RCTs, the outcomes are slightly less positive in real world settings, and that might be something to do with the complexity of the treatment. And so perhaps by simplifying the protocol, it'll be something that can be disseminated on more easily and become more scalable. And it may also give us clues as to how to improve treatments for conditions that have historically been more difficult to treat. So I've mentioned depression already, but I'm just going to, in the last minute or two, mention body dysmorphic disorder. Body dysmorphic disorder, BDD, is a condition that's characterized by excessive preoccupation with perceived flaws in appearance that are unobservable to other people. And people with BDD tend to be highly socially avoidant, and one of the core features is that they worry about negative social evaluation, and it shares many features with social anxiety disorder in that respect. But the outcomes are less positive than we see in social anxiety disorder. And a meta-analysis showed that up to 60% of people with BDD don't respond to CBT. So it's really important that we think about how to improve the treatment, and part of that is understanding mechanisms of change. So just as I finish, I'll throw up a few examples of questions that we might be able to address using the kind of paradigms that we have been developing in the SPRISE study. So for example, can positive surprises in social situations reduce BDD symptoms? And if so, does that actually impact on self-concept? Can it actually start to shape the way people with BDD see themselves and their self-perception? And is self-focused attention similar in BDD to how it presents in social anxiety? And can it be manipulated in a similar way? I think these are really key questions for treatment going forward. So I'll just finish by mentioning all the amazing team of people working on this study, including our collaborators in Oxford and the core team at UCL, Dr. Marjan Birria, Dr. Maddie Payne, Charlotte Berman, and Eleanor Baghdades. And I will stop there. Thank you very much.
Thank you. That was really excellent, Georgina. Help me understand better what we're doing. So this was really great. Now we will turn to questions. So who wants to start with questions? Who wants to go first? Please raise your hand. For those who don't want to speak, you can always write in the chat and I will convey your question. Professor Widding.
Just a quick thank you both speakers for really excellent and really interesting talks. I've got a question for Catherine. So I'm sure you've thought about it. I may have even missed it in the talk, but how are you sort of working around acceptability of taking drugs, and how do you think that might actually even impact who ends up coming to these sorts of studies? So there is, I think it was really interesting, you touched on the fact that people don't really understand how they work, and that perhaps this sort of fear of the unknown and this idea that we shouldn't meddle with our brain chemistry can sort of get in the way of some people who could actually be helped from taking the drugs. So is this something that you do with your young people think about how you might communicate about this in a way that could perhaps increase acceptability of people giving it a go?
Yeah, I think it's a really good point. And I think from the young advisors that we've had on board, that was a really key theme. But although they actually reported finding it quite acceptable to consider, especially given how ill they were at that time, to consider taking antidepressants, but they did find or say that that there was a lot of kind of pressure from their environment, from their family, from their friends, who maybe didn't understand so much. So I think it is really important to think about the acceptability. Obviously, we have to. It's not that I think everyone should take antidepressants. Of course, you do have to kind of weigh it up, but it, like any other medication, for any other thing that you might consider taking medication, there's always going to be some side effects. There's always going to be some risks, but it can also be life-saving for many people as well. And so it's just making that judgment and that balance. But I think reducing the stigma and making it more acceptable as an option to consider without sort of blanket kind of rejection.
And I find it fascinating that for a lot of physical health conditions, we don't have the same thing, even though we don't expect them to necessarily work for everyone. And we expect that you have to try the dose to get it right, whether it's hypothyroidism or something else. But that just doesn't seem to come with the same stigma. There seem to be very sort of strong views about this, and which you see on social media as well. So I was just fascinated by that in relation to the work that you do.
Yeah, and I think it's really, really important that knowledge does reduce stigma. So the more we know, I think the more it will reduce the kind of pressures that are outside everyone, either way, to take or not take antidepressants.
Thank you very much. I can see, I'm now from my own name, as you can all see, I can see Dr. Heyman has raised her hand. Isabel, please go ahead.
Thanks. Thank you both for really lovely talks. It's more of a comment, but it kind of follows on from Essie's point that I think we often don't realise that public and patients don't understand that neurocognitive or cognitive or behavioural analyses are mechanisms. They think of mechanisms as being, molecules or receptors or neurons. And it came out so strongly in both of your talks. I'm going to use them both as examples. But I think we really, the mind and body thing is so important, because I work mainly with people with somatic symptom disorders, and Trudy Chalder's just written recently about how in chronic fatigue, for example, the focus on a physical treatment, which must mean a drug or understanding a mechanism, which must be a chemical imbalance, just needs to be expanded for people to know that psychological mechanisms are mechanisms. So I don't know, they're difficult concepts to get across, but I think putting it across in a few words is so helpful for the public who still don't realise what a powerful science experimental psychology, clinical psychology is.
I completely agree with that. I think it's a really good point, and I think it's quite a contentious issue, because I've even been warned, don't call them mechanisms on a grant panel, because you'll be rejected by the kind of the people doing the molecular and cellular work. We've got to think, hang on, we need to campaign that these are mechanisms. It's just a different level of description, and one that's actually kind of closer to the clinical experience. So it can be really useful in many ways. Yeah, it's an interesting discussion, because of course the molecular people kind of may object, because they have a high degree of manipulability of their systems with reduced biological kind of proximity very often, right? Like a different species, for example, or lack of models of the disease. Like, how would you model BDD in a mouse, right? In rodents, it is very difficult. Even depression, as we know, is a contentious issue about what exactly is being studied in an animal model. But they, of course, have typically much greater capacity than neuroscientists have. It's different with hematology and other areas where you can have the tissue available, of course. Is there anyone else who wants to ask questions in this theme of causes, mechanisms, what they are? I don't know whether Professor Reuser has any views on this. Who's a prime example of a person working on mechanisms. Do you have any comments, John? Can you hear us?
Well, thanks very much, Argyris, and thanks to both the speakers. I mean, to me, it seems almost self-evident, I suppose, because I was trained in experimental psychology, that if you're going to explain how something works at a psychological level, a psychological mechanism has to be a thing that can exist in the same way a social mechanism can exist. And they may reflect changes in brain circuits. I wonder if that might be something that people could take more seriously from a biological perspective, but there's no reason to think that these are mutually exclusive things. I think maybe that's the key point, is that people often think, well, if you've got a mechanism at one level, then you can't have a mechanism at another level. But in fact, the total opposite is true. Every mechanism that we think about in this field has to have its expression at multiple different levels of explanation. The important thing is not to privilege one over the other, or if we are going to privilege one over the other, for example, because some things we can easily intervene on, like in psychological therapy, whereas some things are very difficult to intervene on, like the structure of someone's DNA, then we make that clear. And yeah, from a public communication perspective, I'm not sure exactly what the right answer is to try and sort of address this myth that's grown up over the years. I do think we also have a responsibility as scientists to dispel the kind of simplistic explanations, which unfortunately have left us a little hostage to fortune over the years around things like the serotonin hypothesis of depression, which was never really specified in that form in the first place, but it have sort of become almost like a cultural artifact, and unfortunately occupy a position in the culture wars nowadays. So yeah, I think we have to take that responsibility to communicate the nuance of what our explanations actually mean, and when we are trying to communicate to the public, even though we might simplify the language, not to simplify the ideas, because we can't just go around telling people that they're depressed because their serotonin levels are disrupted without providing the context in which we think that is really meaningful. And I think it has been a problem that generations, in particular of doctors in primary care, have sort of grown up with this explanation and to communicate it to their patients. I don't believe that any psychiatrist would actually say that to a patient, or maybe you can correct me if I'm wrong, Argyris. Have you ever told a depressed patient that their depression is due to low serotonin? I'd be very surprised if you have. But I do think it's a commonly used explanation when doctors are trying to motivate why they want to give someone a particular medication. It comes back to this point that Kath made towards the beginning of her talk, which is that people do like to know what the explanation is, and that's why the mechanistic research is important. So hopefully, with Wellcome funding all of these amazing projects, and we've got a project ourselves, we will be able to move beyond these rather simplistic explanations. And frankly, it's never been possible before because nobody's ever really been persuaded to invest the money in doing it. I wish the NIHR 30 years ago had decided that psychological mechanisms or any other type of neuroscientific mechanism were a valid thing to study, and that we could have applied for funding, in their EMI scheme. But they, every time we applied, they always turned us down. So thank goodness we have finally got to a stage where the science is sufficiently mature that the funder is willing to make that investment. There's clearly a lot further to go, and it'll be very interesting to see how it develops over the next decade or so.
Thank you. This is a very helpful intervention, Professor Reuser. I just to switch a little bit. Eva Sprecher on the chat is asking a question which I'm going to read out, if that's okay with you. These were very fascinating talks. Thank you. I was curious regarding Dr. Krebs' talk about the mechanism of social surprise in the treatment of anxiety. I wonder if this may explain treatment-resistant anxiety, where young people may be living in hostile or challenging social environments. Do you have any thoughts on how we might support interventions for these young people that facilitate these experiences? Great question. Thank you. Dr. Krebs, would you like to respond to that?
Yes, I can try. That's a really interesting and helpful point. I think so I suppose implicit in what you're saying is that if somebody is experiencing negative social interactions, it's essentially kind of confirming their negative predictions constantly, and may therefore be fueling their social anxiety and making it difficult to recover from. And I think that is definitely plausible. A few things come to mind. I mean, certainly in working with adolescents with social anxiety, where bullying or peer victimization it can quite commonly be a feature, then pragmatic interventions to address that can be a helpful component of the treatment. But I also was thinking back to the point that Professor Harman made in her presentation about often our interpretation of situations is what's really important as well. So I think sometimes an environment may be being reported as a sort of hostile or negative, but that might be more to do with sort of negative appraisals and interpretation and perception of the environment. So I guess that's something in therapy that we have to carefully tease apart. And then the third thing that I would say is that often people with social anxiety disorder have had negative experiences in the past, whether or not they're ongoing, and that the memories and often quite sort of intrusive memories and imagery around that can be a factor that feeds into and maintains their social anxiety. And in those situations, it's sometimes important to try and kind of modify and update the images and memories as well, almost in a way that you would do for somebody who has PTSD as part of the treatment. So I don't know if that addresses your question, but I think it's a really important point. Thank you.
So could I just add from the antidepressant field as well? It's a very, I think it's a really important point that we often think that, you know, you take an antidepressant, it's going to work no matter what, or not work, you know, depending on various biological kind of factors. But actually, it does. A key hypothesis is that the effects of antidepressants, if they're being mediated via changes in cognitive bias and looking at new evidence in your environment, that if you are in a particularly challenging or difficult environment, that may limit the ability of the antidepressant to work as well. So it's a really key factor, I think, that we need to consider for psychological treatment, but also for drug treatment, which is a bit of a kind of change, I guess, in how we would typically think about antidepressants, that it's actually working with your environment, not necessarily just sort of flowing through and changing things kind of without any work on your behalf as well. So I think, yeah, that is a kind of potential parallel between the two fields.
Very helpful, thank you. Emily Hurd is asking a question again for Georgina, saying, do you think that there might be a point where the magnitude of surprise would be too large to elicit an improvement in mood, because the distance between an expectation and new information is too large for the new information to be believed and incorporated? Or would you predict that more surprise would always have a greater benefit for mood? Georgina?
Such an interesting question. I don't know the answer, but it's something that we hopefully will be able to test and look at, and we're interested in precisely these kind of questions. So yeah, you know, is one big surprise better than a series of kind of medium surprises? Is there such a thing as a surprise that's too big? And I think that's definitely kind of plausible. I can see why you're asking the question, because if it's so far from somebody's self-concept, sense of self-concept, then it's something that could potentially be discounted. So, you know, you think, oh, that went brilliantly well, but that was a one-off, that was a fluke, or they were just being nice because they had to, they didn't really mean it. And that's certainly something we've talked about a lot, but in sort of setting up this study. So I don't have the answer, but it's something we're interested in, and we can hopefully get at with the data that we're collecting.
Yeah, exactly. If I may add to this, that this is precisely where it would be helpful to model the data, to use computational modeling for the data, something we've done before with mood in different tasks. And this is very exciting because it is a social task, and it seems to be creating surprises and prediction errors. So there may be a saturation either because of the frequency or the magnitude of the difference, in which case there shouldn't be a surprise anymore, right? There might be a big distance objectively, but not a subjective prediction error. That's right. Great question. Thank you very much. Other questions, particularly from early career researchers, be very keen on that. Dr. Payne, please do ask a question. Yes, there is time. We have a bit more time.
Hi. Yeah, I'm the real Maddie Payne. Thanks so much for really great talks. I have a question for Catherine Harmer. I was just wondering, really, if you had any specific predictions about antidepressant response in adolescents compared to adults. You mentioned a little bit about peer sensitivity and potentially, you know, different responses to rewards. I just wondered if you had any ideas about how their responses might be, you know, special, different, because of their point in development.
Yeah, it's a great question. And we really want to start from kind of scratch thinking about this rather than just taking observations in adults and then kind of applying them to adolescents, which is really how the antidepressant field has worked until now. It's just like, well, this works in adults, so it probably work in the developing brain as well. But I think we do have to consider that it might actually look a little bit different given the huge differences in neural development, cognitive development, social development. And it's too early to say exactly for sure, but we were really intrigued that in our work with fluoxetine and the adolescents and young people that we worked with, that by far the most consistent effect was on the processing of angry facial expressions, which we hadn't seen with most other antidepressants that we'd looked at in sort of people in their kind of late 20s and early 30s. And it's hard to know if that really is a difference because of the age group or because we haven't looked at fluoxetine specifically. But it is very interesting given that one of the key core symptoms of adolescent depression is this proneness to anger and irritability. And it's often described, of course, as by families as a kind of key symptom and is a risk factor for depression. So we're particularly interested in that, but looking at it in terms of processing angry faces is a bit indirect, and that's why we really wanted to use some more sort of frustration-based kind of tasks that made sense to young people with depression, to kind of capture what it is that makes you feel angry and how we can kind of capture that in a task. So that's one of the kind of key things that I think we've got some hints at from our early work. But I think also we know that antidepressants do have a particular effect on your kind of social behavior and your social environment and how you relate to other people, how they kind of relate to you. And so this kind of peer sensitivity, the sensitivity to your kind of peers' opinions is so important, particularly in that age group. I mean, it's important, of course, through your life, but it seems to be particularly important in that age group. So a kind of a medication that could particularly kind of buffer you against that or help you in that process, I think would be really interesting. But we don't have any data yet on that. So it's a hypothesis that it might be particularly helpful facets of improvement with these kinds of antidepressants and might be more important in that age group than in adults.
Great, yeah, thank you so much. I look forward to seeing the results.
Excellent. Any other questions? As I said, particularly to from early career researchers, please also feel free to put them in the chat if that is your preferred route of asking. Who maybe I should ask, is there who works in psychopharmacology of the early career researchers here? And do they have a question for Professor Harmer? It's a great opportunity. Be very, very grateful if any one of you spoke up, and it could be research in psychopharmacology broadly construed. Hi. Go ahead, Maddie. Yes. Oh, who is it? No, sorry.
Hi. Sorry, we have two laptops in the same room.
Yeah,
Can you
sorry.
hear me?
Yeah.
Okay, great. I have Miranda. I have a question for Dr. Harmer, which was when you were talking about kind of like SSRI, like the effects of coming off SSRIs after being on them for a while, and you presented the kind of little schematic graph of like potentially it looking worse or the same. I wonder, is there any evidence or has anyone considered a hypothesis that it would almost not actually return to the negative bias wouldn't return to the previous level? And I was thinking, I guess, particularly in adolescence and a like developing brain, that's been considered.
I mean, it's a really good question and a really good point, because you're right. It's I didn't draw that on the schema, because I suppose the sort of widespread kind of belief is that when you come off antidepressants, your vulnerability to future episodes sort of seems to come back. So the kind of risk of relapse is it does return. So it doesn't seem to give you any longer term protection. And in fact, most people kind of talking about this worrying withdrawal symptoms, that when you come off, you can actually feel even worse than you did before for a short amount of time. But I think you're right. In adolescence, we just don't know. It might be that if you could, I mean, it's at least theoretically possible that if you could learn this, these more positive observations that you've had the chance to kind of integrate from your learning more from the positive experiences, that maybe that during adolescence, maybe that could protect you for longer. So you're absolutely right. I should have put that as a possibility in the diagram. Absolutely. Yeah, it's a good question. Thank you.
Thank you very much for the question, Miranda. Great. And there is one final question, which is in the chat by Sarah Buhler. And this is related to actually to what we've just been discussing, maybe similar to Maddie's question for Catherine. I'm wondering what could be the mechanisms underlying the negative bias construct in adolescence, and whether it's different to what we see in as negative biases in adults. Kath, would you like to respond to this? I don't know whether Georgina has any final comments after that.
Yeah, sure. Yeah, that's a really, again, really good question, really interesting. I think that there haven't been many studies kind of directly comparing these kind of constructs. But I suppose from reading the literature around it, it seems to me that there is quite a good body of evidence for differences in reward sensitivity in learning in adolescent depression that might both lead to these experiences of anhedonia, but also possibly frustration and anger if you don't kind of get what you had hoped to get. So a kind of difficulty in learning contingencies between events and punishments and rewards. So I think that seems to hang together even better in adolescence from the literature than we see in adults. So I think that's a key construct that's really relevant and interesting to consider, and perhaps also this this kind of sensitivity to rejection in peers may be something that is a bit more potent in adolescence. But it's hard to say for sure, because I don't know to what extent. It's just that the kind of researchers have diverged and found kind of fed on to past research, and they've kind of ended up doing something slightly different, or to what extent it is because they are actually different. And so yeah, we will be able to see, we won't be directly comparing them either in our study, but we will be able to see the things that are really hit by the antidepressant that are related to response, which I think will be useful. And it may be that they're very similar to what we see in adults, or it may be that it's a little bit different.
Wonderful. This is great. I want to thank Georgina. Do you have any final comments on this? Actually, sorry.
Well, I was just going to comment on a really nice point that's been made in the chat. I think it was by Eva Sprecher again, asking about the salience of surprise in specific social contexts, so from particular person, particular situation, and particular value traits. And I think that's a really good point. That's often it's there are particular groups of people who people with social anxiety worry about their opinion more, of course, peers being the most common group, and particular traits as well. So in therapy, we make it sort of very idiosyncratic when we're doing confronting social situations and testing out beliefs and so on. And that's a challenge that we have in producing a kind of scalable experimental paradigm. But yeah, as you saw, the virtual players were all young people, because we thought that would be more meaningful than having older people whose feedback they're getting. But yeah, I think it's a really good point that there is context specificity and person specificity.
That's great. I would like to thank both our outstanding speakers and the people in the audience for the fantastic questions. Thank you very much, Kath and Georgina, and we're looking forward to hearing about the results in due course.
Thank you. Thanks so much for the invitation.
Thank you.